Good morning, and welcome to the Women's Health Day of Learning and Luncheon. My name is Madeline Cohen, and together with my sister Barbara, we are two of today's luncheon co-chairs. Thank you for your generous support of today's event. Proceeds from this event will benefit all women's health initiatives at the Mount Sinai Health System. With 7 hospital campuses and over 45 ambulatory practices citywide, there is a Mount Sinai physician within walking distance of us all. The Mount Sinai Health System cares for so many of the people in my life, and I am pleased and honored to support their efforts to improve the care given to women. It is now my pleasure to introduce Dr. Yousaf Ali, Vice Chair for Faculty Affairs and Associate Professor of Medicine in the Division of Rheumatology. Dr. Douglas Dieterich, better known in my family as Dr. D for some 30 years, Professor of Medicine in the Division of Liver Diseases and Director of Outpatient Hepatology, and Dr. Alice Levine, Professor of Medicine in the Division of Endocrinology. You're going to be first?
I'm not going to use the podium, actually. Why don't we do this informally? It's probably better this way anyway, because it's hard to move around. And then they'd have to get up. Anyway, so yeah, thank you. Thank you, Madeline. Actually, I started off in pediatrics. That's how I know her so long.
Thank you, then I'm
That's the point. Anyway, I do mostly liver disease, actually, so we're here to talk about that, and we can talk about a few different things. I just returned from the American liver meeting, the U.S. liver meeting in Boston yesterday, where there's tremendous things going on and all sorts of liver diseases. One of the things that affects the most people in the U.S. is actually fatty liver, and that's caused by diabetes, which is Alice's disease, but actually it probably, and obesity, and fatty liver, obesity, and diabetes all go together. So if we count everybody in the U.S. who have fatty liver disease, it's probably about 60 million people, 60 million people, probably the most common liver disease in the U.S. So that's huge, so to speak. We also, actually, in New York City, just in the 5 boroughs, 59% of us are obese. 59%, actually. That's actually, and of those, we calculate that about 30% will have fatty liver disease, and about half of those will have really serious fatty liver disease called NASH, leading to cirrhosis, liver cancer, all the usual stuff that liver disease leads to. So the numbers are really staggering in terms of what's going on in New York City. We calculated roughly in the New York metropolitan area, if we're counting, sort of the whole metropolitan area, probably 1 million people have fatty liver disease. Actually, that's significant. Now, you also should be happy to know in Manhattan, it's only 42% people are obese. Actually, the Bronx takes the record with 71, and then the others are averaging in the high 50s. So there must be more walking involved in Manhattan. So fatty liver disease is a really big problem in women. It's actually much worse in women. There's a few things that are worse in women, and actually, as well as alcoholic hepatitis is worse in women. Mostly because, there's several technical reasons. One, because alcohol gets absorbed directly from the stomach, and women doesn't really have a chance to sort of move down lower, so it blasts right through to the liver. because women are missing an enzyme in the stomach. And number two, women's immune system are better, so they get alcoholic hepatitis much worse. So actually the worst cases I've seen in the last few years of alcoholic hepatitis are sort of surprises, about, that doesn't mean you shouldn't have your glass of red wine. I'm sure cardiology folks will tell you that that's perfectly okay. Well, when it turns into a bottle or two of red wine a day, that's probably a little much. That's worse in women. And fatty liver, of course, because of diabetes and obesity and the things that happen after menopause. And then finally, the hot topic that we've all been discussing for the last week intensively is hepatitis C. At last, there's a cure that's very easy. It's probably a pretty common disease in the U.S. There's probably as many as 10 million people in the U.S. have it, which could be, 5% of the population or more. And there's a lot of bad press about how expensive it is, how expensive the drugs are. But of course, it's expensive to die from liver disease, as well. It's way more expensive to die from liver disease than it is to take these magical medicines. There have been huge advances. We went from 30 years ago, terrible injections with awful side effects similar to chemotherapy. And now our patients are taking one pill a day for as short as 56 days with a 97% cure rate. It's really astounding, frankly. Even if they have cirrhosis, even if they're obese, even if they're 80, age, sex, obesity, nothing matters actually in this treatment anymore. And all those, race, none of that matters actually. It used to matter actually significantly in the past. So it's a really good time to have hepatitis C. You can tell your friends. Not to go out and get it, but if you've got it already, we can fix it. It's really, it's a good time. The other reports that we saw there were also extremely promising. That we had, there were a lot of treatments for fatty liver disease and fibrosis, scarring in the liver that results as a result of the fatty liver disease. Lots of people taking multifactorial tax towards that disease, so that's obviously a huge issue. And globally, actually the biggest liver disease is hepatitis B. Probably 3 billion people with a B have been exposed to hepatitis B, and 1 billion worldwide have active disease. So it's a real issue. We cannot cure it at the moment. We can only suppress it like we do HIV. But there must be 8 or 10 clinical trials now that we're starting to get involved in at Mount Sinai and other places for the hepatitis B cure. That is, so globally, it'll have a monstrous effect on health. Hepatitis B, actually, in parts of Africa, is still the #1 cause of death, actually. It surpasses AIDS and Ebola, as causes of death. So things are really bright on the horizon for liver disease. And all these new medicines to help us, erase the scarring and cure the diseases. It's a good time to have liver disease of any sort nowadays, because we're doing so many things that are positive. And I think I'll pass the baton then to who's going next, Yousaf?
Yeah. Okay, thanks, Doug. So I'm a rheumatologist, and I deal with arthritis and joint pain. And I've been asked to talk about rheumatoid arthritis. And if I could just survey everyone, can people put their hands up? Who's had joint pain of any kind in the past year? So foot, hand, back, knee, anything. Okay, good.
That's not fair. Who has a liver?
Okay. So this is good because I have the right audience. It's not good that you have joint pain, but it's good that you can empathize. So I'm going to talk about rheumatoid arthritis, which is actually one of the most common inflammatory disorders that we see, and it affects about 1% of the adult population. So if you look in the US, the UK, Pima Indians, Native Americans, it's about 1 in 100 people have rheumatoid arthritis. It affects women to men in a ratio of 3 to 1. So it's much more common in women. What I'd like to do is just maybe start with a story of one of my patients. And this is actually not an uncommon story that we hear. So I had a patient a few years ago who was about a 58-year-old lady who basically developed progressive swelling and stiffness in her joints. And she would wake up in the morning and she would describe herself feeling like an old lady. Took her several hours to get ready in the morning. She had swelling and stiffness in her joints. And she had difficulty opening the lids of jars, and she couldn't open, those milk cartons, which are impossible for anyone to open, but she couldn't open those. And so she decided that she was just getting old and this was just part of her life. And so she did what many patients do, is she just ignored her symptoms. So it took her about 8 months of ignoring this before she went to see her primary care physician. And she went to see her primary care doctor, and the PCP did some blood work, and her blood tests were essentially normal apart from one blood test, which is the sedimentation rate. I know there's some internists in the audience, Jen Kent and others, and it's a very non-specific blood test, but it tells you about inflammation, so it's the sedimentation rate. And the normal should be roughly your age divided by 2. So about 30 would be good for hers. And her sed rate was about 120, so it's very, very elevated. And she was given prednisone, and she felt fantastic on the prednisone. And so she took prednisone for many months, and the problem is every time she came off the prednisone, her disease got worse, and she went back and forward and back and forward. So another 8 months elapsed, and unfortunately, one of the chronic side effects of steroids is, there are numerous, and Dr. Levine treats many of these, so diabetes, osteoporosis, hypertension, cataracts, and so on. So she started to develop some of these symptoms. So after about 16 months, she said, is there another treatment, to her primary care doctor? Is there something else that we could take? And she actually was watching one of these TV ads, and you see all these ads between 6 and 10 p.m. about rheumatoid arthritis and Humira and Enbrel, which I think partly educational, but partly terrify the patients. And so she said, maybe I could see a rheumatologist. So she came to see us, and we basically made the diagnosis of rheumatoid arthritis fairly rapidly in her, and we placed her on a medication called methotrexate. And we were able to get her off prednisone within about 3 months, and she's done fine. The one thing I will say when I examined her is that I was going through my list of questions in terms of tell me about your quality of life and so on. And she's quite a stoic person, as you can imagine. And she said, everything's fine, except one problem is I cannot feed myself. And I said, hang on a second, did you really say you cannot feed yourself? And so she actually had a deformity of her elbow, and she had neck arthritis. And so she actually couldn't lift her fork to her mouth. So her husband, her spouse, would actually cut her food and feed her. And to me, it's quite shocking that someone at 58 suffers for 16 months and is not able to feed themselves and just views this as part of life. So, so just a quick background about rheumatoid arthritis. So it's a relatively common disorder. We don't know the etiology of this disease. The thinking is that there's some stimulus, some peptide, whether it's a virus or whether it's bacteria in your mouth or maybe something in the microbiome of your gut, some bacteria in your gut that is triggering the immune system to produce what we call pro-inflammatory cytokines. So these are mediators of inflammation such as interleukin-1, IL-6, and TNF. And so these molecules circulate in the bloodstream. They go all over the body. They go to the brain and they give you a fever. They go to your joints, they cause swelling. They go to your bone marrow, they suppress the bone marrow, they give you anemia. So patients are fatigued, they're stiff, they're achy, they're tired all the time. And one of the problems with the disease, and it's very different from osteoarthritis, is that it tends to be progressive. So if you don't treat it, it can progress and it can damage the joints, and then you can be left with some deformities. And so our goal as rheumatologists and as physicians is to really identify the disease early and intervene early to prevent the progression. So if you are suffering from these symptoms, or if you have family members or friends who have joint pain, you really want to ask yourself, is it an inflammatory condition, and could it be progressing? So don't ignore it. And if you feel that we're struggling with education, trying to get enough rheumatologists in the community. If you feel that you're not getting appropriate attention, then be your own advocate. Say, can I see a rheumatologist? Can I see a specialist, possibly? So just briefly onto the treatment. So the idea is to arrest the progression of the disease. So the hallmark, the gold standard drug is a drug called methotrexate, which is a bit scary because one of the side effects is it can cause liver damage. And so Doug sees some of my patients, but that's extremely rare. And that should be held in the context of progressive arthritis and progressive joint damage. So if your risk of getting liver damage is less than 1%, but your risk of progression of arthritis is 90%, you have to weigh up the pro and the con. So we start with methotrexate. We often use low-dose prednisone as a bridge. And then if the patients progress, because not everyone responds, then we go to the biologic drugs. And so those are the things you see on TV. So the biologics include Enbrel, Humira, Remicade, Orencia, and those things. And they can sound scary. And if you watch those TV adverts, you think your head's going to explode, you're going to grow a tail, and it's just terrifying stuff. But they're highly effective. And we can really arrest the progression of disease and really dramatically ameliorate quality of life. So a common disease gives you swelling and stiffness in your joints, affects 1% of the adult population, more common in women than men. More than likely, everyone knows someone who's had rheumatoid arthritis. Encourage your friends or your colleagues to see a specialist if appropriate, and encourage them to go on some medication, because we can dramatically alter the quality of life. And I think I'll pass over to Alice.
Okay, thank you. All right, so I'm going to trump both of my colleagues. He said, do you have a liver? He said, do you have joint pains? Has anybody ever worried about their weight? Okay, so that's no contest here.
No one said yes.
They just laughed. Right? So anyway, I'm an endocrinologist, which means I take care of hormones. And hormones, the classic definition of a hormone, is something which is made in one organ, travels through the bloodstream to have a target effect in a different place in the body. And specifically, I take care of a lot of male and female reproductive disorders. I specialize in disorders of the adrenal glands, which are the steroid hormones. But today, because it's so common in females, I was asked to speak about thyroid hormone and thyroid disorders, which makes sense. That is the bread and butter of endocrinology. That is what we see all the time, are disorders of the thyroid gland. And so the thyroid is this little butterfly-shaped gland right at the base of your neck here. And it makes thyroid hormone, which, like any good hormone, travels in the blood and targets many tissues and organs. And it regulates your metabolism. It regulates brain function and mentation. It has effects on the skin, the hair, basically every organ, tissue and organ in the body. And for some reason, and particularly in women, the thyroid gland is often the target of what we call an autoimmune attack. So your immune system was made to protect you against foreign things, viruses, bacteria. It wasn't made to protect you against yourself. You're supposed to recognize yourself as self and leave it alone. So for some reason, the thyroid gland is often seen, particularly in women, by your immune system. It wakes up one day, sees it as a foreign invader, thinks it's doing the right thing, and starts to attack it. And there are attack and destroy cells and antibodies, which would leave you with an underactive thyroid or hypothyroidism. And there are actually antibodies that can stimulate your thyroid, both to grow and make extra thyroid hormone. And that leaves you with an overactive thyroid or hyperthyroidism. These are actually flip sides of the same coin. So oftentimes in the same families, and sometimes even in the same person, you'll have the blocking antibodies and the stimulating antibodies, and they're just fighting each other, and it's who wins out. Eventually, usually the blocking antibodies will win out, and you'll be left with an underactive thyroid. So as I've been in this field a long time, in the hormonal field, I've come to the not very deep conclusion that hormones are like the three little bears. They can't be too hot and they can't be too cold. They have to be just right. So oftentimes people think, oh, it's better to have an overactive thyroid than an underactive thyroid. That sounds good. You get kind of revved up. You have more energy. You lose weight. I've done them both. I've been on both sides of that coin, and I'll tell you, I will take the underactive thyroid any day over the overactive. The overactive was very unpleasant. I had a little bout with overactive, and then eventually became underactive and take some thyroid hormone replacement. The overactive gave me negative energy. It made me very irritable, Maybe I didn't have it long enough, but I didn't lose any weight with that. And the people around me couldn't stand me when I was overactive. As a matter of fact, I had a second bout with it, and the people at work on the 11th floor said, "Did you check your thyroid hormone levels?" They figured out that I was overactive again. So at any rate, the more common is actually the underactive. So I'll spend the last few minutes just talking about that. And so the underactive is called Hashimoto's disease, named after a Japanese pathologist who first described it. So sometimes you'll go to your doctor and they'll say, you have Hashimoto's disease, and that's a little bit scary. All that means is that they have measured some antibodies in your blood, and you have those antibodies. Now, there are many more people that have the antibodies than ever actually develop an underactive thyroid. So once we know that you have the antibodies, your thyroid is a suspect, and we sort of check your thyroid maybe a little more frequently than once a year. If the antibodies destroy enough of your thyroid gland that you become underactive, you can have certain symptoms. In the extreme, you get very, very, very tired. Your skin gets very dry. Your hair can get very dry and brittle. You get slowing down of all the tissues and organs and bodily functions. So you get constipated, sleepy. You can get muscle aches and pains. You can gain some weight. It's not a massive amount of weight, but it's more a slowing down of the metabolism so that life becomes even more unfair, meaning you're eating less and you're exercising more and just nothing is happening. So those are the symptoms of an underactive thyroid, and they can sometimes be, we used to call it subclinical when somebody had a mildly underactive thyroid, and now we think maybe it's not so subclinical. And now we do treat even a mildly underactive thyroid with thyroid hormone, because we found that if you take someone who has a little deficit in thyroid hormone and you give them thyroid hormone and normalize their numbers, they actually can feel better, look better. It can improve their cholesterol profile. It can improve, as I said again, their metabolism, their general sense of energy. So nowadays, especially if you have that marker for the underactive thyroid, the Hashimoto's disease, we're very quick to treat. So what is the treatment? The treatment's very simple. It's thyroid hormone. Thyroid hormone comes in two flavors, T4 and T3. And T4 refers to that it has 4 iodines, and T3 means it has 3 iodines. So initially I thought, oh gee, sounds like T4 must be more potent. Actually, T3 is a little bit more potent. However, interestingly, your thyroid gland normally makes T4, the one with the 4 iodines. And it travels in the bloodstream, and each tissue and organ, as it needs thyroid hormone, takes off one of those iodines and turns it into T3. So most endocrinologists like to, when we give thyroid hormone replacement, we like to give T4 because that's the more natural one, actually. And it also is the kinder and gentler form of thyroid hormone. So it kind of takes a little while to build up in your blood. But on the flip side, for a medicine you have to take every day for the rest of your life, if you skip it here and there, it's no big deal. You don't have to double up on it. T3, the one that isn't primarily made by your thyroid gland, that one gives people like a little jazz, a bump in the morning, and then it goes quickly down. And as particularly women, when we get older, we don't really, endocrinologists don't like to give much T3 because it kind of can jazz up the heart and have some ill effects. And T4 usually really does the trick. So that's pretty much hypothyroidism, and now I think we're going to open it up to questions, right?
There's there's several in the back there.
I think we need a moderator.
Yes.
Hi, how you doing, man? I was wondering about hypothyroidism. My mom
Had which one? Hyper?
hyper.
The overactive.
The overactive.
Okay.
Yes. So what actually causes that? Where does it start? And
So there are several different causes, but the commonest cause is an antibody that your own body makes that stimulates your thyroid gland. They're called TSH receptor antibodies, and it makes the gland grow and make more thyroid hormone. And that's called Graves' disease. All right, so that's probably what your mom had. I'm just guessing that she had Graves' disease.
Yeah, she had it for a long time. So they couldn't, because it was almost like it was normal, and she had like symptoms that was like similar to like other diseases. So they treated her for everything else other than that. So, but then I brought her here, and it was, I don't know, they identified what was wrong with her and put her in the treatment, and she was good. Now, this is another question I have. Can you pass it down to your children, or is it hereditary?
Yes, so these thyroid diseases, autoimmune thyroid diseases, are very, very common, particularly in women. There are some theories why women get it more than men, but they're, at this point, pretty much just theories. It runs very strongly in families. So I was going to say that your thyroid is, as I put it before, a suspect, okay? Because thyroid disease is common in women as it is, and with this background, your mom having the overactive one, which is a little bit less common than the underactive, you're at risk to have some thyroid disease, and it could be either way. It could be the overactive or the underactive, because as I said, they're kind of flip sides of the same coin. So the best example I can give you are the Bush family, as in George Bush Sr. and George Bush Jr. Okay, so George Bush Sr. had Graves' disease. He had the overactive thyroid. I don't know if those of you who are old enough to remember, he went to a state dinner in Japan, and he threw up. It was not very elegant. And it turned out that he had the overactive thyroid. He had Graves' disease. And he was president at the time, so they quickly treated him. There are 3 different treatments for Graves' disease. One's medicines, one is surgery, where you just actually remove the thyroid gland, and the third one, which is what Bush Sr. received, is radioactive iodine.
That's what I gave her.
Right.
Yeah.
So radioactive iodine, it's not as like science fiction as it sounds. It's been around for more than 100 years. And what we do is we take advantage of the fact that the thyroid takes up iodine. And so we tag the iodine with a little bit of radioactivity. And what radioactivity does is it kind of is doing surgery without a surgeon's knife. It gets into your thyroid gland, and it destroys the thyroid gland. So it's the same as removing the thyroid with a surgeon's knife. So he was treated with radioactive iodine because he also had an irregular heartbeat, atrial fibrillation. They wanted to nip that in the bud, so they treated him right away. His wife, if you remember Barbara Bush, of the big white pearls that she was always covering, her thyroid was probably enlarged, she had the same disease. She had Graves' disease, but poor thing, she was in the 10% that also got an autoimmune attack. There's a little cross-reactivity with some of the muscles that are sitting behind the eye in the orbit. So she got those, her eyes looked very pushed forward and prominent. About 10% of people with Graves' disease get that. So the husband didn't get that, but she did get that, and I think she probably had some surgery to decompress that.
Okay. Last question, I promise. So what kind of advice would you give me, or what should I look for? What can I do to prevent, or just to prepare, or I don't know.
You can't really prevent it. There's nothing that we know where you can prevent it. These things often come up around reproductive issues. So thyroid disease and other autoimmune diseases often present right after you delivered in the postpartum period. That's a big trigger for this. Yeah. So during pregnancy, if you think about it, your immune system has to be very quiet because half of that baby's proteins are different from yours. And so during pregnancy, all of these autoimmune diseases, and my colleagues can attest to this, they all tend to get kind of quiet. And then about 2 months after you deliver a baby, that's considered, the postpartum period is from 2 months to 2 years. That's when all hell breaks loose with the immune system. It sort of has a party because it can. And that's when thyroid diseases often present. So timing-wise, that would be a time. The symptoms of an overactive thyroid tend to be the opposite of what I said for underactive. So it tends to be being very revved up, inability, like nervous and jumpy, hot all the time, heat intolerance, losing weight inexplicably, but a big appetite. Those are the symptoms of the overactive thyroid. In addition, it's really easy for your doctor to just do one simple blood test and see whether you're overactive or underactive. I don't think you need to be going in for these blood tests every month if you're not symptomatic of anything. But I would say if you go for an annual visit or a semi-annual visit, they can check a blood test called a TSH. And that's the best blood test we have. And in most situations, that test, which I get back in about 2 hours, I call the patients as they're walking out of my office. I have the result already. It tells us, it gives us a window into this, whether you're a little underactive or a little overactive.
Thank you. Thank you.
What's the normal level?
The normal level for TSH? That's a good question. So the normal level in most labs is listed as like something like 0.4 to 4.5. But we think we know better. So those normal levels were actually culled together from so-called normal thyroid people, but a lot of those people probably had some subtle abnormalities of thyroid hormone. So the TSH, which is the best test that we have, is a little bit confusing because TSH isn't made by your thyroid gland. We're not measuring the thyroid hormone levels. And the reason we don't do that is because your body protects you against being very underactive or very overactive for as long as it can. So the actual thyroid hormone levels may not be off. So what is TSH? TSH is made by the pituitary gland, which sits like here, and that's your master gland. It's a giant sensor for what's going on with all the hormones. And TSH means thyroid stimulating hormone. When the pituitary senses that you have even a little too little thyroid hormone, it starts to pour out TSH to try and whip that thyroid into submission, to make more thyroid hormone. When the pituitary gland thinks that your thyroid hormone levels are a little too high, it shuts off TSH. So once we're treating someone, let's say for an underactive thyroid, our target range for the TSH is between 1 and 2. That's it. That's what we aim for. And thyroid hormone, because it's such a common illness, the underactive thyroid, it comes in every flavor, color, shape, and size. And any of us can get someone. Some people need a little more. They don't absorb it as well. Some people need a little less. We can get that TSH to between 1 and 2. And then in terms of symptoms, and particularly weight issues, I tell my patients, once their TSH is between 1 and 2, you have to stop blaming the poor thyroid. Okay?
There were a few other questions on this side. Yes, the gray.
I have a question for Dr. Ali. Oh, thank you. So you gave the example about the woman who waited 16 months and couldn't feed herself to finally seek treatment.
Yep.
At what point should you say, maybe I need to go and speak to a specialist? What should be the dropping off point, do you think?
Yeah, I mean, it's everyone gets aches and pains as we just demonstrated. So I think if you have persistent joint inflammation and pain, if you have limitation of motion, you're having problems making a fist, and it's really affecting your quality of life, that's the time that you should be going. Now you can get, as you know, if you get the flu, you can have aches and pains with that. That's not something you need to get immediate attention for. But if you're having visible swelling and you really cannot make a fist or have problems with grip, probably at least, if it's been going on for 6 weeks or more, you need to see a specialist. So about 6 weeks. Yeah.
That's not related to like an injury.
Mike's down here in blue, lady in blue.
Oh.
Sorry. Yeah.
Thank you. That question,
We have a mic for you. Hold on.
Oh, hang on.
question for Dr. D.
Oh,
Elevate.
sorry, I didn't know that was for me.
Oh, okay. I have questions for you, for everybody. I just wanted to know, elevated triglycerides,
Does that have any bearing on elevated liver enzymes?
Yes, quite frequently, actually. That's part of the whole fatty liver issue.
Fatty
So lots of times the internists will send patients to me who have elevated triglycerides and have a little diabetes, and liver enzymes are really high, and they're afraid to, and high cholesterol, they're afraid to give them anti-cholesterol medicine or even diabetes medicine because their liver enzymes are high. But the fact that they have high cholesterol and a little diabetes is the reason their liver enzymes are high. So they say, we're afraid to do it, you do it. So I'll do it, I do it, and then I send them back and say, look, they're fine. Okay, liver enzymes came down, take your cholesterol medicine and tune up your diabetes, and then go back to your internist.
Do you have a number that your triglycerides and your liver count should be as normal?
No, yeah, normal is good.
Yeah, what would that be? What would be the numbers on that, basically?
Oh, well, most people measure the normal liver enzymes, ALT and AST, and the upper limit of normal is usually 40. Although, as Alice said, we have the same problem actually because of the doing the labs on 10,000 people at Mount Sinai to make it normal. Truly healthy ALT, particularly actually for women, is about 12 or 14. For men, it's about 19. And triglycerides should be about the same number as your cholesterol, 200 or less.
Okay, well, if you don't have high cholesterol, but your numbers are up on your triglycerides and liver, is that quite unusual? Is it usually all three?
No, actually, triglycerides go along with diabetes, actually. So if
Okay.
your sugars are up, that drives the triglycerides up, and that causes the fatty liver issues.
Okay, all right, thank you. Can I have a question for you? Having a hysterectomy, would that cause a change in your thyroid?
Not that I know of specifically, but the other thing I should have mentioned is that as women get older, maybe because the autoimmune attack has been going on longer and smoldering, thyroid disease, particularly underactive, becomes just much more common. So I see a lot of women in the perimenopausal, menopausal years who come in with a mildly underactive thyroid. So not particularly the hysterectomy, but just the fact that time is going on and the autoimmune attack is probably smoldering.
Okay, thank you very much.
Where else are we here? There's a lady with her hand up right here.
Hi, this is for Dr. D also. You mentioned fatty liver and all these other conditions, but when should a woman be aware of, are there symptoms that we should be looking for? How is it detected? And just in general, what should we look out for?
Yeah, I mean, there's nothing you can feel, and frankly, that's part of the big problem with all liver diseases. By the time you have any symptoms, it's usually close to being too late. So we hope that doesn't happen. So I think the same thing that sort of Alice was talking about, sort of routine. Most of the time when you go to your doctor and have blood tests done, they do liver enzyme tests, and that's sort of the easiest way to find out. But I do think you have to be a little bit more sensitive than that, and that's what I was just saying. So lots of times if your enzymes are 40 and not 14, like I said, or 12 in women, that's actually not normal. When they looked at 100,000 people in Korea, actually, who applied for life insurance, if their ALT was less than 20, their life expectancy was normal. If it was less than 40, though, their life expectancy was 9 times worse. Actually, less than 40, which is still considered to be normal in our system. And of course, if it was higher, then it was way higher than that. And obviously, this is not a health study. They just care about life insurance. But it's actually significant risk for dying at a younger age if your liver enzymes are elevated. So it's worth investigating if the cause, and the most common one is fatty liver, diabetes, et cetera. But there's obviously other ones that we talked about, as well.
I have a question for Dr. Ali. Can you talk more about the television advertising that has had an impact on whether or not people get treated?
Yeah, is that the commercial with the 2 bathtubs, Yousaf?
That's the Alice.
Maybe you could explain that.
That's the men's lunch.
That sounds like an illegal program you're watching. Don't endorse that at Mount Sinai. I think that, it's an interesting question. So I used to be really against direct-to-consumer advertising until, like the example I gave you, where one of my patients saw something on TV that said, ask your rheumatologist, And then they came to see us, and they were correct. They had an autoimmune, they had inflammatory arthritis. So I'm in two minds about this because it does increase anxiety of patients as well. And you see the TV ads, and it's like, oh my God, could I have this disease that might damage my joints? So I think it can drive patients to see the specialist, which is a good thing, but it can increase anxiety as well. I think one of the problems with the adverts is that, let's say with the biologic drugs, they tell you about, they have like Phil Nicholson, how he can play golf again and he's fantastic. And then the last 30 seconds is the blurb about how sudden death can occur, and if you take this drug and you can get fever, chills, histoplasmosis, TB, lymphoma, cancer, and everything.
Hepatitis B, don't forget.
Hepatitis B reactivation. And then you're left thinking, well, why on earth would anyone sane take this drug? And so that's a real challenge. And I think that's the legality of, I won't say anything anti-American, that's the legality of the US legal system. And so people, the drug companies have to cover themselves because these things are extremely rare, but they can occur. The molecules that we're blocking with these drugs have survived evolution, right? These molecules have been in our systems for, throughout evolution. And so when you have an inflammatory arthritis like rheumatoid arthritis, the pendulum has swung. So you have too much inflammation, and that's causing joint destruction and damage. So you block that. And you have to there's a sort of fine balance. You need some TNFs like TSH, like thyroid. You need some, but not too much and not too little. So I think the answer is I'm in two minds. I think there's some good, but there's some bad. But if it brings the patient to the physician and accelerates early diagnosis and improves the quality of life of the patient, I think it's a good thing.
I was going to say, just as a comment and also a question for you, I think it's interesting because I'm not involved in rheumatology or rheumatoid arthritis, and because of the ads, I thought that those were the first-line drugs. And you just said today that methotrexate is the first-line drug.
Correct.
So I think that's where it
Yes.
kind of may do some damage because people probably, they say, well, I saw this on TV, but you're telling us that that's not the first-line drug.
That's correct. And if a patient and if a patient comes to you saying, I want Remicade, and that's a $24,000 a year drug. Right. Methotrexate costs $400 a year. So you've got $400 a year, $24,000 a year. And as physicians, when patients come to you with an expectation of a certain drug in mind, and if you say no, the patient's satisfaction goes down, they leave dejected, and so it makes the interaction more difficult sometimes with the patient, as you know.
Although actually, our hepatitis C commercials, if you've seen those recently, we've had two companies just begin to advertise because they have new drugs. Some of you are shaking your heads. You've seen those, actually. They're probably pretty good because they're very non-specific, and they're suggesting, like the CDC started to suggest, actually, a couple years ago, that all baby boomers be screened for hepatitis C. If you were born between 1945 and 1965, you should be screened so we don't have to know, so no one has to ask you about any of those things you did at Woodstock, if you even remember. So all you have to do is be born between those two ages, and you can go ahead. So actually, in that case, Yousaf, it's helpful. They're not pushing a single drug yet. They're sort of mentioning the company's name, but they're not. So if they're encouraging screening, and we get more people screened and tested and treated.
Ethical advertising is good.
Yes.
Yeah.
We all agree.
Yeah.
How is reactive arthritis different than
Right. Right, great question. So the question is, how is reactive arthritis different from rheumatoid arthritis? So reactive arthritis is the body's reaction to a bacteria or a virus or an infection that then activates the immune system that then causes inflammation. So it's a slightly different. We used to call this disease Reiter syndrome after a guy called Hans Reiter, who we no longer use that terminology because Hans Reiter was actually an SS officer in the World War II. And so he was a convicted felon, so I don't think we should be giving eponyms after people like that. So we've removed that term, but the sort of prototypic disease would be someone that goes, like a bunch of college students that go to, let's say, Mexico, they get sort of traveler's diarrhea, they all come back, and then everyone's fine, everyone resolved, but one of those individuals, presumably someone who's genetically predisposed to arthritis, has a persistent arthritis. So the infection has triggered the immune system, and that causes an arthritis. The pattern of arthritis is quite different. It tends to be asymmetric and what we call an oligoarthritis, so it affects usually less than 4 joints. So it's the knee swells up, the ankle swells up, sometimes they get low back pain. So it's really a reaction to an infection, which is slightly different from rheumatoid arthritis because we don't know the trigger for RA as yet.
And does it eventually go away?
It often goes away, so the prognosis is better.
Good.
Yeah, the prognosis is better than rheumatoid, and we can also there is some evidence that if you give antibiotics, that can actually ameliorate the disease. So sort of removing the bacterial pathogen or the trigger can actually cure the disease sometimes.
Does it come back?
It's uncommon to come back. So it's usually a monophasic disease. You treat with antibiotics, it goes away. But some people develop chronicity, but it's rare.
We
Is
have a
it
mic on.
normal?
We have lots of questions in the back now. Oh, I'm sorry, finish. Go
Is it
ahead.
normal that it would be someone would take that antibiotics for 2 months?
Yes, that's normal. So a prolonged period of antibiotics, usually 2 to 3 months, is appropriate. Lyme disease would be another example of a reactive arthritis. Get bitten by a tick, infects you with this Borrelia spirochete, and then you get an infection and you get arthritis and so on. So you give antibiotics.
Thank you.
This young lady here has a very urgent question.
How does osteoarthritis present itself differently than rheumatoid?
Okay, so
Rheumatoid arthritis.
great question. So how does osteoarthritis differ from rheumatoid? So osteoarthritis, unfortunately, is the attrition of life. We all will get that, and we all have that as we get older. And so really the difference is that the cartilage, which coats the bones, basically wears out with time. And if you ever had an arthroscopy, if you get your knee scoped, what they do is the surgeons go in and they scope it with these arthroscopes, and they look, and the surface of the knee is a pearly white, comes as a pearly white appearance. And the reason it's white is because it's avascular. There's almost no blood supply. And the problem with that is that the normal healing of cartilage occurs by diffusion as opposed to blood supply. So as it wears out, you don't get healing. So it's an irreversible process. So this is one of the commonest questions we get asked is, I've got arthritis in my hand or my knee. What can I do to prevent or decelerate or reverse that? And that's, and the answer I give is, if I knew that, I'd be living in Geneva probably. And it's really, because the question they're asking is, how do you prevent aging? And it's an aging phenomenon, which is really an unsatisfactory answer, right? Because we want to be able to, so there's some work on stem cell transplants and so on, but they're really not effective at this point. So if you have a big defect in your cartilage, you can actually fill that in with stem cells. The problem is that when they go in and scope the knee looks pristine, but the patient still has pain. So it's a much more complex neural pathways. But the difference is it's a degenerative mechanical process that usually affects 1 or 2 joints, usually weight-bearing joints, as opposed to rheumatoid, which is a systemic autoimmune disease which gives you inflammation in the small joints of the hands and the feet.
So I've read that you can get hepatitis C from like a bad manicure, like unsterilized, or even if you get your ears pierced. Is that true?
Yeah, absolutely. Actually, I've had a few cases like that. I won't ask who's had a manicure. Actually, yeah. So yeah, it's easily spread by blood only, blood to blood. So an unsterile, ear piercing at the mall, or a manicure, with somebody that's just been cut. Anybody ever get a cut when they had a manicure? Probably, yeah. It's like, and then they put the scissors in that blue viral culture medium, like that, and stir it around a little bit. Right. Yeah. So it's all possible, actually. So I mean, honestly, I don't think it's just baby boomers. I think, well, number one, if you're going to get manicures, bring your own stuff. I don't think you want to be borrowing the, depending on the neighborhood you go into. But I've had a few cases post manicure, actually, acute hepatitis C, as well as ear piercings, tattoos, anything that involves blood to blood transmission. It's not sexually transmitted. Actually, from male to female or female to male. That's not it. But yes, manicures are a risk. Actually, also boxing and rugby. So in case any of you participate in those sports, okay, actually, you're probably safe there. Yeah, okay. Well, because of the blood-to-blood transmission. Actually, New York State requires a hepatitis C test before every boxing match. For either fighter. Actually, man or woman. Actually, I got a patient that way who was a woman fighter, actually. He was diagnosed, actually, before her bout, and they wouldn't let her fight because she had hepatitis C.
Question?
Is thyroid, Hashimoto's, is there a correlation between Hashimoto's and other autoimmune diseases?
Okay, so that's also a good question. So Hashimoto's is such a common autoimmune disease that we're not really, our radar, it doesn't light up the radar screen to look for rarer ones. But if somebody has one of the rarer autoimmune diseases, such as Addison's disease, which is an autoimmune attack on the adrenal glands, which leaves you with low cortisol and low other adrenal hormones. If you have Addison's disease, then we definitely look for other autoimmune diseases like the thyroid. But the thyroid is being the most common. Other than making us suspicious that other people in the family, or you might have the overactive plus the underactive, no, I don't usually do a search then for the other. These autoimmune endocrine diseases are very popular among presidents of the United States. So the most famous person to have Addison's disease, and he did have it, was JFK, John F. Kennedy, had Addison's. Little fun fact.
How common is it to have nodules?
Oh, so.
Repeat the question.
Okay, so the question is about thyroid nodules. Ooh, that's another whole cottage industry. So thyroid nodules are also very common, and people who have Hashimoto's disease or Graves' disease can have nodules. We used to feel very reassured when someone who had Hashimoto's or Graves' had a nodule. We said, oh, there's no cancer in there. That turns out not to be true. You're probably just as much at risk, which is not a very high risk, to have a small focus of thyroid cancer in a nodule in a patient with Hashimoto's or Graves'. But because, again, thyroid nodules are so common, particularly in women, the percentage of those nodules that we have to worry about is really very, very, very small. And this has actually been the reason I said it's a whole other cottage industry. I think it was about a week or two ago in the New York Times. It was a front page story that in Korea, since they started screening people for thyroid nodules and doing little sampling on all of them, they've suddenly had an epidemic of thyroid cancer. So there's a whole question about over-screening people, because most thyroid cancers you probably don't even need to know about. So there's been an epidemic of thyroid cancer, but no change in how many people die from thyroid cancer. So, so that's a whole nother sort of public health issue, is how much do you screen for these things? So the short answer is that thyroid nodules are very common, particularly in women. The percentage of those that have any degree of thyroid cancer is very small. But generally, once it's discovered, you will see an endocrinologist, not me, because I don't do that. And they will do an ultrasound-guided biopsy, take a little sample of it.
And then I guess the follow-up would be, when is the determination made to take the nodule or part of the thyroid out?
So
if the biopsies are coming back fine.
Right. So if the biopsy is fine, it's a little bit of an individual decision. So one of my mentors, who's still in practice and still is wonderful, is one of the people who does these aspirations and ultrasounds, is Dr. Terry Davies, who's from England. And like you, he has a beautiful accent. And all I remember when I was in training, he's not that much older than I am, but he was my teacher, he said, thyroid nodules and young people are best separated. That used to be his story. And I think the idea behind that is, once you know that you have this nodule, nobody can really tell you with 100% certainty that there's no little small focus of cancer there. So yes, if we've had repeated nodules and they were biopsies and they were very reassuring, and you can live with it, you're still going to be monitored. They're going to be doing an ultrasound once a year or something and doing a biopsy. If you can't live with that, they have all different forms of thyroid surgery nowadays that are very minimally invasive with a minimal scar. It's sort of more ambulatory surgery. So that's an individualized decision as to whether you just want to be separated from it.
As a follow-up question to that, assuming your thyroid comes out, how is it living without a thyroid?
Well, it's actually fine because all of us who have an underactive thyroid, we're basically living without a thyroid, and you just take your thyroid hormone pill every day. So that's an easy organ to, I mean, I don't want to belittle the thyroid, but we do have thyroid hormone replacement, and that's all that it's doing. Okay, so we have the pill to replace you with. So again, it's an individualized decision. My husband is a surgeon, he's a urologist, and he always says to me, don't let them fool you, there are no small surgeries. He said, you know, so it is a surgery, but as surgeries go, it can now be done sometimes, as I said, under local anesthesia, and it's a decision-making process. This is not, you know, this is not set in stone. It is set in stone if they do a biopsy and it comes back definitely thyroid cancer. Then you want it out.
Sorry, ladies and gentlemen, that'll be the last question. I am so sorry. And please don't forget to take your...
I learned a lot. I learned a lot from both.
Please don't forget to take your journals with you because your table numbers are on the back. Thank you for coming.